today's clinical meeting, WBAP clinical meeting. Good afternoon to everybody. I think we have a really exciting case list to listen to today. And I thank the faculty and the PGTs of the Imambara District Hospital for taking up the challenge and presenting the cases to us today. Thank you also to all the audience members who have linked in to listen to this clinical meeting, and I request the presenters to kindly start.
Thank you, ma'am. Am I audible?
Yes, clearly.
Good afternoon, everybody. Thank you, ma'am. Thank you, sir, for giving me the opportunity to present my case. Absent radius, look before you lynch. I'm Dr. Hooghly Chattopadhyay, PGT Pediatrics, Imambara District Hospital. This is my case, 2.3 kg weight, 7-day-old, late preterm baby girl admitted with cleft lip and cleft palate with malformation in both forearms. We found that the baby was late preterm, 35 weeks, girl baby, born with non-consensuous marriage, no drug history for the mother, no significant history of perinatal asphyxia or PROM. Vaccination was up to date up till date, and they are in the lower socioeconomic group. The parents were on lower socioeconomic group, and there is no significant family history of any congenital disease or limb abnormalities. On clinical examination, we found that there is no history of conversion and hypoplastic forearm, clinically palpable one bone. Probably that was ulna, and radius was not palpable. There is no significant cyanosis for the baby. Anal patency was checked, that was present. Genitalias were normal. Autonomy test was done. There is no hip dislocation. Ballard scoring was not done due to inability of the forearm properly, due to the forearm is not properly developed. Neuromuscular maturity cannot be assessed, but physical maturity was assessed. The lab investigations, we found surprisingly that platelet count was 35,000. In the peripheral blood smear, there was no abnormal cells. Significantly, ABG was normal. There is no evidence of sepsis. Their torch screening was done, that was negative. Karyotyping was done, that was 46XA, that is normal. Maternal platelet count was done, that is 2 lakhs. X-ray of the full body done, and there shows there is absence of radius in both forearm. USG whole abdomen was done. Kidney size was normal up to the mark. Liver spleen was normal. Uterus was normal. Now, in this scenario, there is a thrombocytopenia and absent radius. We can assume few causes of thrombocytopenia. Most commonly sepsis, DIC, or there is a neonatal autoimmune thrombocytopenia, but the investigation shows there is no evidence of sepsis, no evidence of neonatal autoimmune thrombocytopenia. Maternal platelet was normal. We have to judge further the platelet aggregation test, platelet function test, and human platelet and antigen test for the baby. Next, due to there is absence of radius and thrombocytopenia, we should assume few syndrome in this baby, like Holt-Oram syndrome, TART syndrome, Fanconi's anemia, and Vattel syndrome. As we all know, that the syndrome are the repetitions of few sequences or symptoms in a baby that is commonly occurred together. So our first differential diagnosis was Holt-Oram syndrome, and before that, echo was done. Echo was perfectly normal except some PFO with left to right shunt. There is no structurally abnormality found in the heart. Now the question is, can it be Holt-Oram syndrome? That strike in our mind that it is mainly a cardiac limb syndrome, mostly associated with ASD, but there is an association with VSD also. But there is no association in our case with cardiac involvement in this baby. And moreover, the Holt-Oram syndrome is a autosomal dominant inheritance. So in this case, presuming the family history was correct, that there's no limb deformity, the Holt-Oram syndrome was unlikely. Another thing is that their thumb is present and that is intact in this case. And mostly in the Holt-Oram syndrome, the thumb is generally absent. Not in everyone, but generally it is absent. The next topics was the Fanconi's anemia or pancytopenia. That can happen because there is some amount of low birth weight. As the balance coding was properly not done, it can be a radial ray defect is there, that a hypoplastic thumb or aplastic thumb that is not here, but that is commonly occur in Fanconi's anemia. But more interestingly, Fanconi's anemia is associated with pancytopenia. Here there is no evidence of pancytopenia. Hemoglobin level was normal, total count was normal, and no abnormal cells are there. Cardiac association happens in Fanconi's anemia, but not present in this case. And the skin, there is no skin pigmentation in our baby. And Fanconi's anemia is autosomal recessive. Next, it can be a Bacterial syndrome, unlikely because there is no vertebral anomaly as seen from the X-ray. There is no atresia, no tracheoesophageal fistula, no renal abnormalities was found. Next, the last one but not the least, there is a TARS syndrome or thrombocytopenia with absent radius. That can be the case. Thrombocytopenia, their thumb is present in the all the 100% cases as described, 100% cases of TARS syndrome with bilaterally absent radius. Ulna is normal in this case, but many cases ulna is underdeveloped. Association with cleft palate, that is very important with TARS syndrome or thrombocytopenia. Thrombocytopenic crisis because the platelet. Further investigation was planned because we are not still sure that is a Fanconi's anemia could be there or that can be a TARS syndrome. Or we should go with chromosomal fragility stress test to differentiate with the Fanconi's anemia. As you know, there's Fanconi's anemia, there is chromosomal fragility test, it will be positive. And specific for the TARS syndrome, we will go for deletion analysis for 1q21 chromosome because it contains the culprit gene RBM8A gene. Here that is showing in the picture. So to diagnose the TARS syndrome or the absent radius with thrombocytopenia, to confirm diagnosis, we should go for the genetic testing and the clinicals one. Absent radius, presence of thumb and thrombocytopenia. Yes, thrombocytopenia is there in our case. Absent radius is there. Presence of thumb is there. Genetic testing, many studies have shown that to establish TARS syndrome, genetic is not always mandated, but it will be better if we can show that. Now, management. As cytopenia is a grave crisis, and in our baby, the platelet count, although 35,000, there is no evidence of pitting, no evidence of conversion. As the convulsion rules out the significance or any irritability, as the convulsion or irritability is not there, that rule out the major vascular hemorrhage in brain or major vascular event. And if platelet count goes down 25,000, we will go for platelet transfusion without bleeding, and in bleeding less than 50,000. That scenario doesn't happen in our case, but if it's present, we will go for that. And importantly, in all TARS syndrome, it is noticed that all the thrombocytopenic crisis occurs within the first 1 or 2 years of life. So we will be very cautious in the first 2 years. Protection from acute hemorrhagic crisis, as I have described, that in the first 2 years of life. Cleft palate surgery and cleft lip surgery, it is there. So we should undergo the cleft palate surgery for the feeding. And in the TARS syndrome, like all syndromic approaches, we should go for a multi-specialty approach with orthopedic surgeon, plastic surgeon, cardiologist, and behavioral therapy, occupational therapy, and supportive therapy to the patient when he will grow up and the parents. There is a higher association of AML has been found with this type of TARS syndrome. Here we have shown the platelet pouch Generally, we do platelet transfusion and always squeezing is there that the platelet is not doesn't clump. Now, what should be the diet? To avoid thrombocytopenic crisis, if to little bit of hemorrhage, we should avoid sharp bordered foods. And most interestingly, these TAR syndrome babies are suffering from cow milk protein allergy. It occurs, it precipitates thrombocytopenia, it precipitates leukomyte reaction. TC count will go up. These babies also found to be have eosinophilia. And eosinophilia, high TC count and the dropping in the platelet count will be very much dangerous for this baby. Avoid injury at the it is also that is very important for these babies. Activity like the picture shows, there is a soft covered helmet, there is a soft covered pad in the knees, and to protect from the contact trauma, wearing helmet with and support knee is very important for these babies. Care of the knee is very important because many times it is found that the baby is suffering from dislocation of patella, there is bony deformities in lower limb and various different skeletal. Handling of the babies in the small, when there is a newborn time period, 6 months time period, these babies, because padding of the crib or the bed is very important. Surgical corrections is many times advised, but that is not routinely done. Splinting of the hands can be done. Adaptive device was planned for this baby in our case. Adult case, if the thrombocytopenia is present, that is very rare. Although very little cases have been case reported has been done, and there's a little role of splenectomy has been found for these cases. Now, antenatal screening. Antenatal screening, USG screening is mandatory in further pregnancies for these parents because it can be diagnosed on 16th week, the absence of radius. As we all know, there is an association, there is a syndrome, there is a symptoms of radius absence, cardiological event not present in, at least not significantly present in our case, but with thrombocytopenia, all because of that is probably it occurs develops in the same time period, like 6 to 8 weeks of gestational age. So around 16 weeks, it will be perfect for antenatal screening to diagnose whether the radius is present or not. Thank you. That's in my presentation. Here is showing one lady that is doing her normal activity, having the TAR syndrome, and all the TAR syndrome babies can live their normal lives. There is no hurdle. The main problem is within the first 2 years, we have to protect the baby. We have to very much meticulous about the platelet count for the baby. Thank you.
Any questions from audience, judges? You didn't explain your name, the name you have given to the presentation. Look before you lynch.
Patient, absent radius, look before you lynch.
Yes.
I can't get point.
So look before you lynch. Why did you give this name? Does the lynch word, it usually means beating up someone, right? So what was the meaning? What did you think of behind giving this name?
Because in these babies, many times as there is syndromic babies, many times suffer social disrespect, social unfollow and detachment from the fellow friends, family members, and many of the parents, because all the socioeconomic groups, as there is a higher in our country, they think there's all the syndromic babies or any type of syndrome is the by their wrong thing they have happened, or the God is not happy with them, so they beat their child. So there's a higher incidence of battered baby or higher incidence of uh, baby beating in this all the syndromic cases because they are not properly educated about the disease and the disease progress.
Okay.
So,
And any history of consanguinity?
this is non-consensuous marriage.
Sorry, non-consanguineous. Okay. Any more questions? Dr. Bashudev Patra has a couple of questions in the chat box. He has written, what about pregnancy planning in the future? And please clarify what you mean when you say food with sharp border.
Like food with sharp border, I can say that's a cornflakes or hard biscuits that should be avoided in the first 2 years of life. That can hamper the baby. And yes, that is the autosomal recessive disorder. So in the further pregnancy, that can happen, that cannot be happen because we don't know the amount or the autosomal recessive repetitions pattern in this case. We know that the autosomal recessive is 4:1, but we don't know the total number. So antenatal screening, that is very mandatory for the parents. We should go for the antenatal screening.
And will you be able to do genetic screening in this child, do you think?
Yes, yes, we will go for the genetic screening in this child. We'll go for the genetic screening.
Okay, any other questions?
When does a child develop patella? You said that there is chance of patellar dislocation. The picture that you have shown, according to that picture, I'm asking that when does that patella develops? Does a child in picture develop patella?
No, there's a chance of patellar dislocation. Not in this time period. There is a later life, in the adolescent life or after 7 to 8 years, there is a chance of patellar dislocation. Coxa valga is there. There is a chance of coxa valga.
But the child in the picture had the knee protection pad, isn't it?
There's a knee protection pad is there because to avoid the injury.
Injury to the knee joint itself, not only patella.
Total knee joint to save the total knee joint.
Okay.
Support in the knees.
Okay, we can go to the next case, I think.
Thank you, ma'am. Thank you, sir.
Good afternoon, one and all. Am I audible? Is the screen audible, ma'am?
Can you just go to display settings and then swap your screen? Display setting on top of the slide. The extreme, right on the top,
Yes,
on
ma'am.
the extreme left. Yeah. Right, please start.
Good afternoon, one and all. Myself, Dr. Koral Bhanushali, pursuing DNB Pediatrics in Imambara District Hospital. So the case, this is the twisting 21. So what is about the 21? Let's come to the case. So there was this baby, 1-month-old male infant, and he was referred from a private pediatric practitioner with complaints of vomiting and poor sucking, which had started within 2 days after birth with failure to thrive. The causes were not known till now. The baby was increasingly lethargic over last 2 days. On detailed asking, the vomiting was scanty, non-projected, non-bilious, at the same time unoffensive and non-blood stained. Weight of the child presently being 2.3 kgs, with birth weight being 2.123 kgs. Mother was a registered ANC case, and also on detailed information, we got to know there was a history of drug intake, that she had gestational hypothyroidism and she was on the tablet levothyroxine with the dose stated above. Child was a product of lower segment cesarean section, was a preterm and low birth weight, who cried at birth. There was no history of any neonatal asphyxia. Was a product of a non-contiguous marriage, and he came from a low socioeconomic family. On detailed examination findings, the child was sick looking. Vital signs stated as temperature being normal, 37 degrees Celsius, heart rate 180 per minute, with respiratory rates being 60 breath per minute. BP on the subnormal level, like is 55 systolic and diastolic 32 millimeters of mercury. Capillary referring time was less than 3 seconds. And on taking the capillary blood glucose, it came out to be 43 milligram per deciliter. On head-to-toe examination findings, the positive findings which we got to know was some kind of dehydration status seen in the baby at the time. We saw the anterior fontanelle was sunken, eyes sunken, skin was dry and non-lustrous. At the same time, the oropharyngeal mucosa was sticky, abdomen was mildly distended. On examining the genitals, there was subtle hyperpigmentation which was seen over the genitalia. Penile length was 3.2 centimeters and both testes were descended. So with this BP, the subnormal level, the child was immediately admitted. We and managed with vascular access was obtained, and we managed to bring up the glucose since the glucose was around subnormal levels. 10% dextrose was given, IV bolus. Fluid deficit was corrected and it was maintained on intravenous fluids. So before starting the broad spectrum antibiotics, the empirical antibiotics, we sent some routine investigations. Sepsis screen was done, lumbar puncture, because we thought it could have been some meningitis or some infection, and blood for culture and sensitivity was sent. And then the empirical antibiotics were started. So on further going through the case, we came out to some differential diagnosis being, it could have been a GIT cause, could have been hypertrophic pyloric stenosis. It could have been renal causes on pump failure or a polycystic or renal disease. CNS lesions could have might been meningitis, infections, endocrine and metabolic abnormalities. With this, congenital adrenal hyperplasia was also kept in mind. So till evening, we within 2 to 4 hours, we got the lab findings being CBC, the values were within normal limits. Only the TLC counts were a bit on the higher side. It was around 14,540. On the biochemical analysis, CRP was raised. The thing which couldn't, which could have been missed is the electrolytes here. Serum sodium being on the subnormal side, the potassium being on the higher side, 5.6 milligram per DL. Chloride was less, 72 milliequivalent. Calcium being low. So if it could have been recurrent vomiting, the potassium should also have been low, but it was 5.6 mg per day, which was a striking feature and which made us scratch our heads. On renal function test, the urea was 22 and creat being 0.8, as seeing as the dehydration status of the patient. Liver function tests were under normal limits. Since seeing the antenatal history of the mother, we thought of going through the thyroid profile. which was under the normal limits. Imaging studies were done to rule out the other differential diagnosis, where X-ray was done, it come out to be normal, no subacute any obstruction was seen. USG whole abdomen showed no features of any idiopathic hypertrophic pyloric stenosis. No Mullerian structures were, extra Mullerian structures were present. USG brain suggested normal, no other features were seen. So with keeping all this in mind, the electrolyte disturbance and all, we came out to a diagnosis being a provisional diagnosis to be a case of congenital adrenal hyperplasia. And since it was a salt wasting kind where we can see the sodium being so low, we could not help, but we had to start the patient on hydrocortisone until the further tests arrived. So we counseled the patient since it was a low socioeconomic status, and since our hospital has some limitations on investigations and all. So the blood samples were sent for the enzymatic assays being serum cortisol, aldosterone, and 17-hydroxyprogesterone in a private lab. And when the results arrived, the 17-hydroxyprogesterone was twice the baseline level, serum cortisol and aldosterone being on the lower side of the cutoff. So with all this, we had a final diagnosis for the male infant being congenital adrenal hyperplasia with a classic variety of 21 hydroxylase deficiency salt wasting type. So coming to the, since it's all congenital, so coming to all the intrauterine part and the biochemistry part of the adrenal gland. So since we all know the function of the adrenal gland being synthesis of aldosterone and cortisol and testosterone. So the biochemistry part, all the medical fraternity present here, I know most of them would hate the biochemistry part, but still this is the pathway here. So 21 hydroxy deficiency which occurred more than 90% of the CH. So we thought of it to be most commonly in our case. And the thing is, why we solved, there is a two type of variety which we see, which is a classic variety and non-classic variety. So our patient presented with the salt wasting kind, which was an acute presentation, acute to subacute presentation, being since it was lethargic since 2 days. So in the salt wasting kind, we could see the enzymatic level of 21 hydroxy deficiency is almost nil. In simple visualizing form, it is around 1 to 2%, and the non-classic being there's a range to 20 to 50%. In the virilization kind is severe in the salt wasting kind. So although our patient being a female patient, ambiguous genitalia, the virilization part would have been very evident, but it was a male child. So to come to the proper diagnosis was a bit tough. So coming to the genetics, as we all know, the 21 hydroxylase genes are being CYP21P and CYP21. 21 being the active gene, and basis on their mutations, we have three kind of variety as stated above. Also, I would like to point the thing that is the Ehlers-Danlos syndrome, which is also present on the DNA of this 21 hydroxylase deficiency allele. So also it has to be kept in mind. So here I have taken some pictures from the Nelson textbook of pediatrics. It's the prenatal androgen excess, where you can see the where the fetus have been already exposed to the increased androgens in utero life, and we can see the clitoromegaly and the fusion of labias, and it appearance to be shown as a testis, pseudotestis. In the postnatal androgen excess, we can see the child, a 5-year-old male child, but looking as a 12-year-old, has a masculine feature, the penile length being more the pubic, the secondary characteristics has been seen, and there's a precocious puberty has been achieved. Coming to the newborn screening, also in the HAPCON, I think there was this topic raised about how to incorporate this CH screening at birth, because it has been seen many of the cases have been missed by this. So this salt wasting kind and all these severe cases could have been screened before, since the objective is to early intervene and early treat the patient. So 17-hydroxyprogesterone levels can be incorporated for the newborn screening. Then I have made a table showing how the other enzymes in the CH being 17-hydroxy, 11 and 3-beta will present. So 21 and 3 beta being the extreme kind, they show a salt wasting crisis with virilization. In 3 beta, it is coming to the pathway. 3 beta is required for all the formation, that is aldosterone, cortisol, and testosterone. Only the problem is in 3 beta, it will be the DHA will be raised, which is a mild androgen. So virilization would not be evident in 3 beta. And coming to 17 and 11, it is a salt retention kind, and where there will be ambiguous genitalia and increase in testosterone. So the approach, I made a simple approach. Like if we are seeing any salt wasting kind with sodium being less than the normal with high potassium, if yes, then it could be a 21 hydroxylase deficiency or a 3 beta hydroxylase steroid dehydrogenase deficiency. If no, then it could be a 17 or 11 hydroxylase deficiency. Coming to the increased testosterone levels, as we can see virilization in males as precocious puberty or in females as ambiguous genitalia or secondary sexual characteristics. If yes, then it could be a 11 or 21 hydroxylase deficiency. If no, then it would be a 17 hydroxylase deficiency. And in since 3 beta, it is some of the virilization we can see. Okay, I rest. This is my time. Thank you.
Hello, Dr. Sushmita. Can I say something?
Yes, Dr. Kalpana, please.
Yeah. So it's a nice presentation, but I think you must be knowing that in that any male child presented in the newborn as having the hyponatremia and hyperkalemia, and means mimicking renal failure, AKI, without having in features of sepsis or AKI, it is salt wasting. This is a dictum. Always we rule out the salt wasting in a male child because it's a difficult until you suspect and do the investigations. And I think not only hydrocortisone, fluorocortisone should have been added as there is a hyponatremia too. And they will die of hypotension. So that should be, I think it should be maintenance to be given like a fluorocortisone and a hydrocortisone both. And
I
second,
was going to ask that. So if you could give your management in a little greater detail. You just said hydrocortisone is added, but what is the maintenance? What do you do at times of stress? Do you
this
add
is very important.
fluorocortisone? What do you do about
Ma'am, yes, in the treatment part, we started after the diagnosis, we maintained the patient on hydrocortisone at 8 to 10 milligrams per meter square of the surface area. And fluorocortisone was also started with 0.05 mg per day. And also sodium chloride tablets were also provided to the patient along with that.
And thereafter, did you check the sodium? Because you have added sodium chloride. Actually, sodium chloride is not needed. You have to for long-term therapy only hydro and
Yes, in the maintenance therapy. Yes, ma'am.
And in stress, what do you advise? Stressful situation. In stressful
in case of stress, we will double the dose. In case of mild stress like infections, we will double the dose of the steroids. And in case of surgery, like in severe stress, we will triple the dose of the steroids.
There are thank you. There are some more questions in the chat box. Can you see them? Ideal replacement therapy, I think you have spoken about. Any comments about IEM screening, inborn errors of metabolism, the routine screening? Do you think there are some studies, there are some diseases that we should screen for in all babies if possible?
I think there are these 5 basic diseases should be screened. That is hypothyroidism, galactosemia, phenylketonuria, G6PD deficiency, and CAH.
And probably, yeah, right. Any additions to that? Kalpanadi, Dr. Dash, Dr. Bhuya?
Nowadays, CFTR gene also doing everyone, no? Cystic fibrosis and all.
Cystic fibrosis, yes.
Yeah, but if you have a female child, then it would have that ambiguous genitalia. Rather, we should say now DSD. Now we don't say intersex, no, don't say the ambiguosity. Now we say DSD. The latest term is the DSD. So as you have a epispadias, you said. Did you look for the testes in the site?
Yes, ma'am. Testes were seen. Both were descended, and in USG there were no Mullerian structures present.
Okay. And any phimosis or any other? I think you have written epispadias, no?
Yes, ma'am.
Something.
Yes, ma'am. Epispadias.
So the urethral in the normal side. Urethral
But-
opening is in the normal side.
Sorry, ma'am.
Urethral opening is in the normal side.
It was urethral open was a bit above the normal side.
So
Upper.
it is one of yeah. It is so it is a one of the DSD.
Yes,
So you
ma'am,
have
one
to
of
be,
the days.
keep your antenna high whenever you get the DSD, and you have to look for the hormones and all those things, especially in a male child, because in male child you won't get the DSD. And female it is quite obvious. And did you measure the light as a male child? No, okay, clear.
Yeah, penile length was measured, ma'am.
Yeah,
Was
it is
3.8
normal.
centimeters.
It's the-
Yeah,
yeah,
it
it's
was
normal.
stretch penile.
Thank you.
Thank you. Shall we go ahead to the next case?
Thank you, ma'am.
Slide is visible. Oh, ma'am, slide is visible.
এখনো স্লাইড শেয়ার হয়নি, ওইটা ক্লিক করো, হ্যাঁ, যেখানে তোমার অ্যারো। Lot of endocrine cases, it seems. কি হলো? ডক্টর বাসুদেব পাত্র জিজ্ঞেস করছেন, তোমাদের হাসপাতালে কি কি ইনবর্ন এরর অফ মেটাবলিজমের স্ক্রিনিং হয়, রুটিনলি কি কিছু হয়?
হয়নি, আমার হসপিটাল কিছু হচ্ছে।
You can answer at the chat box.
পিটি ওপেনে from beginning করছি, তারপর এসছে। Screen is visible. Hello, ma'am. Screen is visible. Hello.
Slideshow mode করো, not in slideshow.
Can you make it in slideshow mode? ওপরে হ্যাঁ ওইটা ক্লিক করলে কি হচ্ছে না? আগে হলো তো। না না ওই লেফট এর যেখানে তোমার হ্যাঁ ওটা ক্লিক করো। হচ্ছে না তাহলে এরকম করেই শুরু করে দাও।
Am I audible, madam?
Yes,
Yes.
audible. Yes.
Good afternoon to all, sir and ma'am. My name is Dr. Vikram Mali. I'm second year DNB PGT from Imambara District Hospital. So today my topic is hypoglycemia. So here is case history. A baby of Varshashau, 21 days old male baby from Pandwa, presented with persistent yellowish discoloration of face, eye, body, and recurrent vomiting with fever for 3 days. Baby was on mixed feeding, breastfeeding with for some time formula milk also. So on admission and physical examination was done, and on admission that baby was on lethargic, and temperature was slightly in higher range. CBG was lower, so hypoglycemia 36. CBG was 36. Heart rate was respiratory rate, SpO2, and CRT. Other finding was in normal range. On physical examination, icterus was present, mild pallor was there. There was no cyanosis or no edema was there. On systemic examination, like hepatomegaly was 3 cm hepatomegaly was present below right costal margin. Spleen but not palpable, and significant eye finding was there. So there was bilateral both eye, there was cataract was present, and genitalia was normal. So other than this, there is no physical abnormality in other part of the body. So initially the hyperglycemia was there, and fever was there.
Excuse me? Can I interrupt? It is still not visible in a slideshow mode, so it's very difficult to see.
So screen is not visible. And now screen visible.
স্লাইড শো মোডটা হচ্ছে না। কল্পনা দি ওরা করতে পারছে না, ট্রাই করেছে অনেকবার কিন্তু স্লাইড শো মোডটা হচ্ছে না।
একটু আস্তে আস্তে।
আই থিংক একটু নেটওয়ার্ক প্রবলেম হচ্ছে বোধহয়। বৃষ্টি পড়ছে কি?
এবার হচ্ছে ম্যাম এখন
না না এখানে এখনো ওই অন্য স্লাইড শোটা আসেনি এখানে।
সাইডে ক্লিক করো, আপনি ডিসকাশন में ক্লিক করো। একবার কেটে আবার চালু করো। Madam, second slide is visible.
We can't see it in slideshow mode. We can see in the normal formatting mode.
See second slide or third slide. If I change this here,
কোনোটাই স্লাইড শো হচ্ছে না। বাট আই থিংক উপায় নেই, তোমরা এরকম ভাবেই বলো কারণ অনেকবার তো চেষ্টা হলো। একটু স্লোলি বলো বিকজ দ্য রাইটিংটা অলসো ইজ নট ক্লিয়ার, সো একটু স্লোলি বলো। গো টু ইওর থার্ড স্লাইড থেকে বলো আবার। থার্ড স্লাইড উইথ দ্য ক্যাটারাক্ট, ওই ছবিটা থেকে।
পাশে করে দেবো। Okay,
madam, so physical examination. On admission, baby was lethargic, temperature was slight higher range, CBG was 30 deciliter, so hypoglycemic or baby was hypoglycemic, heart rate, respiratory rate, SpO2, and CRT was on normal range. And other physical finding was icterus was present, mild pallor was there, but there is no cyanosis or no other any edema was seen. On a systemic examination, there is a hepatomegaly was seen, the 3 centimeter hepatomegaly below right costal margin in mid-clavicular line. Spleen was not palpable, and so significant eye finding was there. There is a bilateral cataract to us. And other than this, there is no other physical finding was there. No normal genitalia was there. So initially, all the fever was there and hypoglycemic was there. So IV blind was established and blood was sent for routine investigation, and urine for also sent for routine investigation, and LP was planned for and later on that day. So initially management was like IV plus was 10% dextrose was given, IV fluid started, and empirical antibiotic was started. Anthropometry wise, on admission, baby head circumference was 34.5 centimeter, chest circumference 32 centimeter, length was 49 centimeter, and weight was 2.9 kg. So in antenatal history wise, there is a uneventful antenatal history. There is no history of rash and fever, and all the scan were normal range. All normal scan was normal. Birth history was non-consanguine marriage. First baby born by normal vaginal delivery, and term baby cried immediately after birth. Birth weight was 3.1 kg. And after all the routine in care, baby sent to mother, and breastfeeding was started after some time. After on the third day of life, mother noticed yellowish discoloration up to leg. So mother came to us, and there is a significant jaundice was there. So baby was admitted in SNCU, and phototherapy was started. After 2 days of phototherapy, baby was discharged with some follow-up advice, and there is no significant family history of, and socioeconomic status was poor socioeconomic status. Lab report of CBC on within normal range. CRP was slightly on higher side, 12 milligram per day, 12 milligram per liter. Total serum bilirubin was done, and it was 11.2 milligram. There was a predominantly direct bilirubin was there. Liver enzyme was slightly elevated. Arterial blood gas was done, so that was also in normal range. Urine and culture was done. Also, there was also report came the normal and negative. LP was also negative side, but there is blood culture positive for E. coli. So here is a positive for E. coli. Then after all the lab report, baby was on under observation. So hypoglycemia was there. So initially blood glucose was monitored regularly on hourly basis, then 2 hourly, then 6 hourly. So we monitored that blood glucose 35 to 65 between that, fluctuating between this, and in between that episode, there is one episode convulsion was also noticed, and that due to hypoglycemia. So managed with only dextrose bolus. So here on there is a 3 finding was there. There is persistent vomiting, persistent jaundice, recurrent hypoglycemia. So and cataract was there. So on these 4 finding, we some differential diagnosis here, like sepsis with hypoglycemia, inborn error of metabolism, like keeping in mind like galactosemia, fatty acid oxidation defect, organic acidemia, and glycogen storage disorder can be the differential diagnosis. Other than this, congenital adrenal hyperplasia with also present with recurrent hypoglycemia syndrome, where cataract can be seen. So for this rule out of or other differential diagnosis, and for making the primary diagnosis, we got like blood for serum lactose, serum ammonia, serum for 17-hydroxyprogesterone, urine for non-glucose reducing substances, and urine for ketones. And 2D echo was also planned, and cross screening was sample. So later this all report came, where urine for non-glucose reducing substance positive, and serum lactose, serum ammonia, serum 17-hydroxyprogesterone, urine ketones, all were came normal limit. 2D echo was also done, so it was also came negative, and cross screening also came negative. So on this basis of this finding, what should be our diagnosis? So our differential diagnosis basis initially sepsis with hypoglycemia. So blood culture was positive, and second the IEM, inborn error metabolism, where fatty acid oxidation defect. So in fatty acid oxidation defect, there is no urine ketosis, but high lactate will be seen. So in our cases, there is no lactate level is normal, so we can here rule out oxidation defect. And second, organic acidemia, where high anion gap, metabolic acidosis seen, high ammonia seen, and cytopenia seen, and other finding hypoglycemia, elevated transaminases. But in our cases, there is no metabolic acidosis. No, there is ammonia level is also came negative on normal range. So we can here rule out here organic acidemia also. Glycogen storage disorder, where hepatomegaly, hypoglycemia is there, macroglosia, sometimes macroglosia is seen, and in Pompe disease, glycogen storage is in Pompe disease, hypertrophic cardiac myopathy was seen. But our 2D echo came negative, normal range, and other finding. And we can here keep in mind that glycogen storage disorder can be possible. But in galactosemia, there is hypoglycemia, cataract, hepatomegaly, jaundice, for reducing substantial these are the findings seen in galactosemia. So in our cases, all these features are present in our cases. Like recurrent hypoglycemia is there, cataract, bilateral cataract there, hepatomegaly is also there. This is there, and urine for reducing substance came positive. So we can make the primary diagnosis as a galactosemia. Other differential diagnosis like congenital adrenal hypertension, there is a normal genital abnormality, and so we can rule out here congenital adrenal hyperplasia and congenital tubular syndrome. There is a three finding. Triad of the congenital tubular syndrome is there: cataract, sensorineural hearing loss, and congenital heart disease, where PDA is predominant. PDA is commonly finding it this way. So we can rule out all these differential diagnoses and making the primary diagnosis as a galactosemia. So we went for keep in mind this galactosemia as more primary diagnosis and manage the. So initially we started lactose-free formula milk, and there are so many lactose-free formula milk available in markets like Isomil, Lexolec, Nusobi, and so many things. So we started lactose-free formula milk and 7 days course of antibiotic, and we surprisingly found that there is baby was improving, total bilirubin was also decreasing, and baby gains 200. So that we make the primary diagnosis galactosemia, and advice after improvement of the baby that we discharge the baby with lactose-free formula milk with proper counseling and follow-up advice that if anything happens, they can take. So our diagnosis is galactosemia. So I will talk briefly about the galactosemia here. So galactosemia is autosomal recessive disease. It's quite a rare disease, and is present at 1 to 47,000 to 60,000 live births. There are 3 types of galactose enzyme metabolism defects in galactosemia. So galactose 1 phosphate uridyl transferase, galactokinase, UDP, galactose 4 epimerase. So any enzyme defect can present as a galactosemia. So here is a normal galactose metabolism pathway. So was galactosemia. So here we will go for first enzyme, that is classic galactosemia. So in classic galactosemia, there is a deficiency in enzyme uridyl transferase. There is 2 forms of this deficiency exist. If this is complete form and partial. So complete form is called as classic galactosemia, and if partial, then they will be present later in a later age, and maybe sometimes asymptomatic can be there. So what is the defect in? There is a mutation in JLT gene, which is located on short arm to chromosome 9. Responsible for this mutation can be lead to galactosemia. In galactose metabolism, there is impaired leading to increased galactose level in blood and urine also. So if this enzyme is deficient, so galactose pathway will be diverted and production of galactolol by the enzyme aldose reductase And galactose can accumulate in various cellular organ like a lens, so there can cause cataract in liver, nervous tissue, kidney, and impairment of their normal function. Second enzyme is galactokinase deficiency. So in galactokinase deficiency is responsible for the phosphorylation of galactose. And then mutation seen in this galactokinase deficiency, GLK1 gene, which is present on long half chromosome 17. So this also stunted formation of the galactylose and that present as cataract and other symptom. Third enzyme is the uridine diphosphate galactose 4 epimerase. This is partly extremely rare. So this is present in 1 into 1 lakh live born. But this can be present like mutation in GALE gene. This is chromosome 1, short arm of the chromosome 1, present on short arm chromosome 1. Symptom is similar with other galactosemia. So symptom wise, there is a serious disease that present in onset of symptom typically in second half of the first week of life. So baby presented with vomiting, diarrhea, failure to thrive, weight loss, hepatosplenomegaly, jaundice, which is a cholestatic jaundice, predominantly cholestatic type, infections and sepsis. So infection is a predominantly E. coli sepsis is a predominantly seen in galactosemia. Mental retardation is seen and severe cases like cataract, amino acid, and albuminuria also can see. Cataract here is a oil droplet cataract is seen in galactosemia. Other long-term features in puberty, there is male gonads are not affected, but female gonads are affected, and then can present with amenorrhea and ovary failure. So infertility seen in the females, and also other symptoms like a cognitive defect in seen in language problems, mental retardation also can be there is present. So how to diagnose galactosemia? So if family history is present or previous baby is galactosemic or any inborn metabolism, so we can go for in prenatal diagnosis centers in polio-based samples, where sample of the fluids from the womb for examining of the cells and levels of the enzymes level. And at the newborn time, newborn screening also done for galactosemia for a sample taken from the baby's heel and test for the GLD enzyme. Urine for screening purpose, urine for reducing substances also can be go for urine for reducing substances. Blood level for erythrocyte galactose 1 phosphate layer. And there is just so many genetics and molecular studies also available that we can go for analysis and diagnose. For treatment part, there is we have to write dietary restriction about and drinks which are containing galactose and lactose. So initially that we have to strict dietary restrictions should be there, and also supplement to be there. Other supplementary things should be give to baby like calcium supplements, vitamin supplements, but by the time of with maturation, most children develop another enzyme which is capable of the metabolizing galactose. So as a consequence, long-term management, we have to follow this patient throughout the life in the OPD basis and dietary compliance, growth, yearly biochemical analysis to be grown greater than the galactylure and red cell galactose 1 phosphate level. Development wise, we have to baby's speech, cognition, motor skill to be monitored. Ophthalmological wise, there is cataract, so vision problem can be there. So surgically, if vesicular surgically treated to be cataract. And further potential therapies for galactosemia is there are so many human trials are undergoing. There is a restoring about GLT activity, enzymatic activity. Gene therapy also is one of the potential therapies that messenger mRNA therapies, which restore the enzymes and improve the galactosemic symptoms. Pharmacological chaperones are there, and these are all the undergoing trials and not easily available on the normal level. There are some studies are undergoing and some screening based also undergoing. One pilot study was done in North Indian population where non-genome sequence based on expanded carrier screening for the genetic disorder. So on this way, the galactosemia they found in some patients. So these are the screening all done in patient. Then pilot study was done on neonatal GLT gene replacement using adenovirus that dramatically lower the galactose metabolite in blood, liver, and minimize the cataract. So these are the study based on animal models. So there is human model study, human trial is not happened there, up to now. And there is one more research is ongoing, like novel mRNA therapy that restore GLT protein enzymatic activity and in classic galactosemia and improve the quality of life. So here I will end of my talk. Thank you, sir.
Oh, Dr. Shishmita, can I say?
Yes.
Yes. There are very lots of points are there. First, I would like to say very nice presentation. Second point is whenever the newborn comes with a hypoglycemia, you must think of with the three diseases. That's very important. That is the galactosemia, tyrosinemia, and fructose 1 deficiency. So, and when is he having a cataract, then it is almost confirmed that this is a galactosemia because it's very common, and whatever the other differential diagnosis you have written are not that common. So whenever you get the hypoglycemia, it is better to do the reducing substance. And everyone is having that dip stick for nephrotic syndrome and all, that you take the stick and see the glucose is there and not. If it is present, then you go see. If absent, then you have to see it is a non-glucose reducing syndrome, NGRS. Reducing substance means it may be glucose, maybe in NGRS. So you have to mention it is NGRS, not glucose, non-glucose reducing substance first. The second point, as I said, you have gone for the progesterone and all those investigation. I think that should have been a secondary or tertiary level of investigation. Always go to primary investigation. Should have been the blood as you look for the galactosemia and testosterone. Others will be in the second because that will cost money, blood, your efficiency, your time also. And then, of course, the galactosemia diagnosis, you must go for the GALT enzyme AC because that will confirm your diagnosis, and rather than other investigation like you said, nicotinamide beta oxidase deficiency and all progesterone, all those investigations quite costly. And you could have done the GALT enzyme. That is the commonest one. Other enzymes, two enzymes, that's very, very rare. And
I'm just curious, the GALT enzyme test was done?
Not in the government setup, we have to do the private.
But what kind of, does anyone know how expensive is it?
Yes, ma'am. In our setup, there is a GALT enzyme test was not done, so we refer patient to the higher center or in the medical college, so where they done this test and we follow the patient that the result came positive.
Yes, yes, that is the commonest one.
Okay.
And another point I would like to say.
But is it very expensive? Is it difficult to do? Because of the
A bit expensive, not that one, but it is expensive.
Because it would give you the specific answer straight away, isn't it? And then you
yes,
don't need to do
and
so
another
many
thing,
other
when
tests.
you've got the E. coli infection, that's very common in galactosemia.
Yes, ma'am.
And sepsis with E. coli is common, causing hypoglycemia is common. Similarly, the vice versa is true. If the hypoglycemia, jaundice, cataract, and you will get the E. coli infection because very common in galactosemia. Okay, so and hello.
Yes, Kalpana.
Another thing you very nicely said, the galactose, you have to restrict the breast milk and all, but baby will be going up after 6 months and all, how long he will continue the galactose free milk and all. So you have to say the diets which are low in galactose or are free of galactose, and the fruits, of course, because very common tendency to feed the child with the fruit, different type of fruits. So can you say some food or fruits or vegetables were rich in galactose you have to avoid in this particular patient?
Actually, I don't know that galactose-free fruits.
No one remembers. No, whenever you get the case, you just see in the net, download and give a list to the parents. That will be better. Like papaya, mushroom, and tomato, watermelon. Dates, these things I just remember. I don't remember the full list. These are the rich in galactose. They should be avoided. Okay, thank you from my side.
Dr. Debjani Gupta had a few questions. Debjani, why don't you, you have a panelist link. Would you like to talk about your questions or any suggestions?
Hello.
Yes, we can hear you.
Yeah. No, one was I was curious to know your lab sensitivity report to E. coli, because so what antibiotics did you use to treat E. coli sepsis? That was number one. And number two was, how did you get on top of your hypoglycemia? Because that was an initial problem, isn't it? That was number two. And number three, you did mention the family profile. So, economically constrained probably I wouldn't know how much of the disease they understood at the time of discharge. So what specific advice did you give at discharge point? You know, how did you make this family understand what to do with this baby when they were taking this baby home? So initial was about the E. coli sepsis. What was your choice of antibiotics after you got the lab report? And how did you get on top of your hypoglycemia? You know, you had this baby who was convulsing. So, so how bad was it?
Okay, quick answers now, okay, because we are running short of time.
E. coli was
Follow.
sensitive for the piperacillin tazobactam. So we initially, before the lab report came, before we started cefotaxime, and then later piperacillin was sensitive for E. coli. Then we started piperacillin tazobactam, and hypoglycemia was initially repeatedly monitoring was there. So in normal times we didn't give for any treatment for hypoglycemia, but later that was the GIR was started on infusion pump. Yes, and urine screening, we in baby as repeatedly on we follow up initially weekly we came to our OPD and later then monthly, and we hearing screening for like hearing screening, we advise for hearing screening, ophthalmological screening as in respective department.
Any advice about next pregnancy?
Ma'am, yes, ma'am.
I think while you're answering the next PPT could
Yes.
be the presentation could be put up.
This is galactosomy autosomal recessive disease. So we advise the patient to, because there is a 25% chances of the disease in the later their subsequent pregnancy, and 50% chances of the subsequent babies. So we advise before planning for the pregnancy, and if needed, then go for the like amniocentesis and CVS chorionic villus sampling for the enzymatic levels and all.
Okay, thank you. Let's
Right,
go
thank
on
you.
to the next presentation.
madam.
স্ক্রিনে কিছু দেখা যাচ্ছে না কিন্তু।
এখন দেখা
This
যাচ্ছে?
is fine.
হ্যাঁ,
একদম
এখন
ঠিক
ঠিক আছে,
আছে।
এখন ঠিক আছে, এখন ঠিক আছে।
Start করো।
Good afternoon, everyone. I am Dr. Sushmita Chakraborty, DNB first year PGT in Pediatrics, Imambara District Hospital, and my topic is Slippery Corridor of Milky Way. First of all, I thanks to everyone to give me the opportunity to present in this topic. In my case, a 3-month-old exclusive breastfeed baby girl come to the hospital with his mother with complaint of recurrent erythematous itchy rashes, mainly over the cheek, elbow for last 7 days, and history of loose stool with blastics 3 to 4 times daily, which is last for about 3 to 4 days, and 3 such episodes in last 2 months. In the birth history, the baby is first child of non-consanguineous Indian couple. The baby was delivered by normal vaginal delivery at 38 weeks and birth weight is 2.93 kg. And breastfeeding was initiated with the first hour of the delivery. In the family history, there is no significant history of atopic dermatitis, any allergic reaction, asthma in her immediate blood relation. But there is significant history of bronchial asthma in maternal grandfather. There is no significant history of any drug intake in pregnancy and lactation period of motherhood. There is no history of any drug intake of the patient of his 3 months year lifespan. Now come to the general survey. In the general survey, the baby was irritable, fussy, cranky, febrile, BP 90/50 mmHg, pulse 124 per minute regular, respiratory rate 40 per minute, thoracoabdominal in nature, no sign of dehydration, there is mild pallor is present, absence of any icterus, cyanosis, edema, clubbing. In the anthropometric measurement, body weight 4.1 kg, length 58 centimeter, head circumference 41 centimeter, chest circumference 39 centimeter. In the local examination, erythematous maculopapular rashes may be mainly over the cheek, also on the flexure aspects of the elbow and inguinal skin fold. In the systemic examination, all the examination of the systems are within normal limit, except in gastrointestinal system. There is mild abdominal distension, may be gaseous, on palpation soft, non-tender, there is no organomegaly, IPS present. Now come to the investigation part. In complete hemogram, hemoglobin 9.8 gram%, that is decreased, and total count 14,300 per cm. Differential count neutrophil 54%, lymphocyte 36%, eosinophil 8%, which significantly increased, monocyte 2%, platelet 2.5 lakh per cm. CRP 8 milligram per liter, that is mildly increased, and other are within normal limit. Next, come to the stool examination. pH 6.1 and yellow ill-formed alkaline reaction with trace of mucus and blood, pus cell present, 12 to 15 per high power field, RBC 12 to 12 by high power field, occult bud present, USG whole abdomen, X-ray, urinary within normal limit. The history and the investigation, we get 4 differential diagnoses. One is atopic dermatitis, the drug-induced dermatitis, lactose intolerance, and cow milk protein allergy. Now, we treated the baby symptomatically with atterus drop and calamine lotion, but the symptom persists. Then we advise the mother to total exclusion of cow milk product from the diet, from her diet. Now, baby improved drastically. When cow milk product reintroduced in the mother diet, within weeks, symptom reappeared. This case was provisionally diagnosed as cow milk protein allergy. Now, patient was referred to the higher center for colonoscopy examination, which confirmed the diagnosis. So, the case is confirmed as cow milk protein allergy. Then the mother was counseled and advised to completely stop cow milk and milk product. Now, as per literature, cow milk protein allergy is the most common food allergy under 5 years of old. The incidence in cow milk protein allergy in infants feed with formula milk 5 to 7% and breastfeed infant is 0.5 to 1%. Casein and beta-lactoglobulin is the responsible for this allergy. Now, the symptom. Now we present the symptoms in a pictorial manner. The patient may be present with back arching, colic, reflux or vomiting, eczema, the itchy rashes, tiredness or traveling in sleep, wheezing or coughing, refusal to feed, constipation and diarrhea. Now, in the next slide, we present the pathophysiology. It is mainly immune-mediated reaction. It may be IgE-mediated or non-IgE-mediated or maybe both. In IgE-mediated, it occurs within 2 hours of exposure. In non-IgE-mediated, it be delayed for several days of exposure. It may be confused with lactose intolerance or GRD. So here I attached a difference between lactose intolerance and milk allergy. In the next slide, the diagnosis part that we already discussed in our cases, here we include the skin prick test, which is positive in IgE-mediated CMPA, but negative in non-IgE-mediated, and serum IgE specific test in positive in IgE-mediated and negative in non-IgE-mediated. Patch test is negative in IgE-mediated but positive in non-IgE-mediated. But skin prick test and patch test are less sensitive. Now, parental management, in case of baby's exclusive breastfeed, the mother should be encouraged to avoid all milk and milk-related products for his diet and should continue breastfeeding. Initially, while confirming the diagnosis, mother should be encouraged to take cow milk protein-free diet for at least 14 days, and if there is improvement is a symptom, she should continue to avoid cow milk protein. Introduction of cow milk should be done after 1 year of withdrawal. If symptom reappears, new or milk or cow milk protein should stop and re-challenge after 1 year. Soy milk is very good substitute in India, but if there is allergy in soy milk, we stop it and use extensively hydrolyzed formula. Supplementation of adequate minerals and vitamin is mandatory. IG-mediated cow milk protein allergy infant can have problem with extensively hydrolyzed formula when we need elemental amino acid formula. Now, take-home message. In our daily practice, we should keep our mind open and should not miss any cow milk protein allergy cases and should deal with the mother proper diet plan, or better to say, we should not miss the case where there is dietetic error in the mother side. Thank you.
Okay, thank you, Shushmita. So, couple of questions in the chat box. First is Atarax. You mentioned that the child had been given Atarax. Is there a minimum age for recommending Atarax? Do you know? Any comments from anyone else?
It's not recommended, but still we have used in our daily practice.
And is it true that most babies grow out of cow's milk allergy with age? And they start taking when they are older, say 2 years, 3 years?
Yes.
Yes?
Yes. Yes, ma'am.
Okay. Any more comments from panelist audience?
Hi, hello.
The IG mediated and non-IG mediated. Both types of CMPA can be relieved normally in lateral life.
IG-mediated CMPA, it presents with more complications like like skin rashes, wheezing, respiratory distress.
Now, which type has a chance of a natural cure? IG mediated or non-IG mediated, or the both?
IG-mediated.
What is the stool pH? You said it is 6.1, then said the alkaline reaction. How come?
It is at 5.5.
6.1 is acidic, isn't it?
Yes.
But you should alkaline in reaction.
It may be in typing error.
Okay. Kalpana, please go ahead.
Okay, from my side, I'd like to say Atarax is not indicated in newborn first. Second is, as you said, the staging is there. First, you stop the cow's milk protein, then you have to monohydrolyze, then amino acid. Even that, if there is no improvement, then you have to take care of the diets of the mother. So, did you go for that? Or what is the stage in your patients? Which stage it was? What restriction you have done in this particular patient? Only the cow's milk protein?
It's cow milk protein and.
Did you go for the IG level? Did you go for the eosinophil count? Did you go for the other test? Only skin prick test? That's all?
Oh, skin prick test not done.
Okay. So what did you do? How did you decide if the IG mediated or not IG mediated?
Ma'am, it is not diagnosed that it is IgA mediated or non-IgA mediated. It is only diagnosed as it is a cow milk protein allergy.
Okay. Okay. We didn't go the further analysis.
Yes, sir.
Okay. So after stopping the cow's milk, baby was okay? Did you
Baby,
follow the growth and development and all those monitoring? Did you do after that?
yes, ma'am. After doing the challenge test, we advise the mother to stop cow milk and cow milk diet for 1 year.
No,
And
you stopped the cow's milk for the mother or for the baby?
Baby was exclusively breastfeed.
And mother was on cow's milk?
Yes, ma'am.
Okay. I got it. Thank you.
Thank you.
So Vijitha, we are out of time. I think if the judges could give their decision and any other comments.
Yes. Dr. Bhuiya and Dr. Kripanath Das. Do you have anything to say?
Physicians. Abhijit,
Follow.
in my opinion, the number one is the speaker who spoke about the congenital adrenal hyperplasia. Trisomy 21.
No, not the number one speaker. Number one was Agnik.
Number two, Dr. Vikram Mali, who spoke about
That means first is Dr. Bhanushali, isn't it?
Hello?
Hello, Parthoda.
Hello?
Hello.
হ্যাঁ বলছি যে এই ডক্টর ভুঁইয়া যেটা বলছেন তুমি একটুখানি ঠিক করে বলে দাও না
কি বলছেন ডক্টর তোরাল ফার্স্ট হচ্ছে ডক্টর তোরাল ভানুশালী
CH
CH
twisting 21
and number
second is
second is
number 3
Agnik Chatterjee.
Bikram
Mali.
Galactosemia.
Then
first, second ही बोला है.
बस ठीक. So
and
first
all the participants get a certificate. Our first, second separate certificates are.